Hello, everyone. I'd like to thank the KDIGO leadership and the two co-chairs of this Controversies Conference for inviting me to talk on this important topic of international perspectives on home dialysis. I'm going to focus my presentation on the global south, since that's the area of the world that I know best about. And I'm sure there would be more discussions around other aspects of home dialysis throughout this Congress, which will impinge more on what happens in the developed world. So these are my disclosures. I work for the George Institute for Global Health. I have research grants from Baxter Healthcare and NephroPlus, and have received speaker fee and honoraria from a few organizations. Not mentioned here is also relevant, perhaps, that I am currently the president of the International Society of Nephrology. So a few years ago, we published this paper in which we, for the first time, actually identified the actual numbers of one of the worst kept secrets in the nephrology, which was around unmet need in kidney failure treatment worldwide. And we showed in this systematic review that all around the world, globally, between 7 and 10 million people need treatment for end-stage kidney failure. However, only about 2.5 million people receive it. Everyone else around the world dies. We also showed in this paper that most of the people who are receiving kidney replacement therapy actually live in high-income countries and upper middle-income countries, and people from lower middle-income countries and low-income countries constitute less than 7% of the global dialysis population. It's worth pointing out that more than 70% of the global population actually lives in these parts of the world. Data from Global Burden of Disease study also has shown that the age-adjusted prevalence rate of chronic kidney disease is really higher in the more deprived parts of the world. And so that is where the future burden of kidney disease is going to rise. As again shown in the same paper that we published 5 years ago, you can see the projected increase in the global dialysis population from 2.62 in 2010, the year for which we had analyzed the data, was projected to go up to 5.4 million people in another 9 years or so. And on the right-hand side, you can see that the largest projected growth is expected in Asia and in African continents in terms of the number of patients that they have currently in those two regions. So what are the various considerations worldwide while people are choosing their kidney replacement therapy options? So people worry about access. People, as well as governments, worry about cost effectiveness. The health system, those in charge of implementing programs, worry about equity, they worry about justice, and everything is embedded in values and preferences of the society and geography where these programs are being developed. From the health system's perspective, peritoneal dialysis, which is a form of home dialysis, is the preferred dialysis modality in terms of returns on investment that the health system needs to make for the health gain that it will get out of the program. Clearly, kidney transplantation is the best treatment option for those who are suitable for such a program in all parts of the world, and so it should be prioritized. However, we also know as the kidney health professionals that a large majority of patients around the world are not really either suitable for kidney transplantation or cannot get kidney transplantation because of a number of other reasons, not the least non-availability of suitable kidney donors. And so they must remain on dialysis for some period of time. And for this section of the population, peritoneal dialysis has been advocated as being the preferable type of dialysis compared to in-center hemodialysis. However, we also know the fact that home dialysis, both peritoneal dialysis and home hemodialysis, is underutilized globally. This is data from the US renal data system, which ranks different countries around the world in order of the proportion of patients who receive peritoneal dialysis in that specific country. And you can see that the country on top is Hong Kong, which has a PD first policy. So there the government mandates that all new subjects who are eligible for dialysis must receive peritoneal dialysis unless there are strong medical reasons for them not to receive this therapy. And similarly, you can go down and you can see the other states that other countries that are mentioned there are Mexico, Colombia, Canada, Singapore, Qatar, etc. And what is important to point out that most of these countries, as well as the countries which are shown on this next slide, that talks about kidney replacement therapy in high-income countries. And what I would like to point out here is that you can see the different bars of home hemodialysis, which is shown in dark black, peritoneal dialysis in the hashed bars, transplantation in the open bars, and facility-based or in-center hemodialysis in the gray bars are shown on this slide. But I would specifically point out that the y-axis actually is a logarithmic axis. So the difference between the two is actually tenfold, and these are not equal. So that's something worth mentioning. And so you can again see that in-center hemodialysis is by far the most common in all of these countries. So between the last slide and this slide, you can note that the countries where home hemodialysis is more popular are countries that have typically a single payer system or a nationalized health service. What about the global south? One of the things that needs to be pointed out that physical access to kidney replacement therapy is a major problem in the global south, something that people in more advanced countries don't often think about, except those living in real remote locations like the Aboriginal population in Australia or Canada and Native Americans in the United States. So this figure shows you data from my country, which is India, and on the left side, you see the distribution of kidney transplant facilities or density of kidney transplant facilities in different states of India. You can see that in relative terms, the southern states are relatively better off, but the northern states and the eastern states are very badly off. And for those of you who don't know the distribution of population in India, the poorest populations live in these states, which have the fewest facilities. And also, according to this study, almost 60% of patients on in-center hemodialysis had to travel more than 50 kilometers to access hemodialysis, and just about 24% lived more than 100 kilometers away from a dialysis facility. So you can imagine that in-center hemodialysis, if it is thought to be as a solution for the problem of kidney replacement therapy, just the access is going to be challenging for a large proportion of the population in a country like India. Also consider a country like Indonesia, which is made up of more than 17,000 individual islands. It helps that not all of them are inhabited, but still more than 6,000 of them are inhabited. Only 4 of 5 of them are large islands. All of the rest are really tiny islands, and setting up individual in-center hemodialysis facility on those 6,000 islands is not a practical solution for Indonesian nephrologists. So when the Indonesian Society of Nephrology, or PENEFRI, came to the International Society of Nephrology for developing a strategic approach to solving the problem of kidney replacement therapy in Indonesia, naturally, we thought together that it is likely to be centered around peritoneal dialysis, which is much more easy to potentially scale up in remote locations. So having discussed those physical barrier problems, what are the other medical barriers as well as health system related barriers to home dialysis? The first thing to point out is that awareness of home dialysis is relatively limited, and the thing that we need to do more than anything else is to educate all the stakeholders, which include policymakers, dialysis doctors, and patients. The second challenge is in getting dialysis access, whether it is peritoneal dialysis catheter access or an arteriovenous fistula in. The third challenge is to ensure that we continue to empower and support the patient during the course of treatment that they get at home, which requires using the right tool for monitoring. And finally, in the list here, solving the reimbursement issues. But I think those are the ones that probably are more important than any others. I'm going to spend just one slide on home hemodialysis, because home hemodialysis is not really a viable, long-term, sustainable dialysis solutions for providing dialysis to patients in low resource settings. And this particular paper talks about some of the barriers and potential solutions to home hemodialysis, which also essentially talk about somewhat similar issues, starting with lack of exposure, visibility, and education regarding home hemodialysis. And the solutions are shown on the right-hand slide. Of course, there is a preconception that hemodialysis is too difficult and complex, and this is going to be even more important in low resource settings where technical expertise is a challenge. Issues about patient confidence, fears of vulnerability, unexpected problems, and fears of self-cannulation are important challenges with home hemodialysis, and they are issues which are common to patients on peritoneal dialysis as well, which is a home-based therapy, including caregiver burden, cost of therapy, and so on and so forth. Now, let's come to the most important topic that we don't often talk about often enough. And I'm sure that this is going to be discussed in greater detail in the next talk, but let's start by talking about the cost of hemodialysis and peritoneal dialysis worldwide. And Dr. Karupati and his colleagues developed this diagram that looks at the relative cost of hemodialysis and peritoneal dialysis in different countries around the world. And it is stacked up in terms of hemodialysis, peritoneal dialysis cost ratio. So here is the line where the cost of hemodialysis and peritoneal dialysis are equal. And countries that are that fall on the right side of this line, in those countries, hemodialysis is more expensive. And in the countries that fall on the left side of this line, peritoneal dialysis is more expensive. And once again, you can see that all of the countries in which peritoneal dialysis is more expensive are paradoxically countries that are either low income or lower middle income countries. They also showed that as the cost of hemodialysis rises in the country, the out-of-pocket expenditure on dialysis goes up in that country. So that's the linear relationship between the two. And the third thing that it showed is that peritoneal dialysis costs are high when peritoneal dialysis supplies need to be imported and or they are taxed by the governments in those countries. So these are two potential challenges which immediately suggests to us two solutions, one of which is local manufacturing of PD fluid, and second is lobbying with the governments to take away any levies or any taxes that the governments impose on this life-saving peritoneal dialysis consumable supply. Many countries such as India and many other African countries have actually tried to provide cost-effective hemodialysis by undertaking cost control in hemodialysis services which are provided in a public-private partnership model. This is data from India, which we published a few years ago, in which we looked at one such model implemented in the state of Andhra Pradesh that announced the policy of providing free dialysis to people below poverty line in the year 2008. We analyzed data for the first 4 years, and as you would expect, the number of people accessing this dialysis continued to go up year on year, which is good news. But the bad news is that the patient survival was not great. And almost 50% of the patients either died or dropped out between 6 months and 1 year of starting dialysis. Given that most of these people were in their 40s or 50s, this is really not an outcome that we expect this population to have. And so therefore, there must be other reasons. And what are those reasons that are shown in this slide, which is taken from another similar program in the southern Indian state of Kerala, which shows that even when dialysis is provided free, a large proportion of patients, more than 90% of the patients, experience catastrophic out-of-the-pocket healthcare expenditure and have to engage in distress financing, which means that they have to either sell their property or take loans or undertake these type of loans, which really have a major impact on the quality of life of their families and pushes most of these families back down into poverty, or if they are already poor, pushes them further down into poverty. And it is estimated that most of this out-of-pocket expenditure is related to other costs in providing dialysis, such as the cost of transport and travel from home to the dialysis facility, and the cost of other drugs that are needed for maintenance of patients while they receive this life-saving dialysis treatment. So as we understand it's taken as a given that peritoneal dialysis is cheaper than hemodialysis in the developed world, and that data I did show you a few slides ago. And this is not the case in developing countries. And so many developing countries are undertaking this exercise of looking at cost effectiveness acceptability curves between hemodialysis and peritoneal dialysis. And this is a publication that looked at the similar cost effectivity, incremental cost effectivity ratios in Indonesia. And you can see that on the yellow line, the cost effectivity ratio is shown for PD first policy, and in the red line for hemodialysis first policy, and in the blue line for supportive care policy. So this identifies really the price point at which peritoneal dialysis becomes the more cost-effective option compared to supportive care. Hemodialysis, under no circumstances, provides a cost-effective alternative, and peritoneal dialysis first policy would provide 193 million IDR per quality in Indonesian rupiah, will cost 193 million per quality adjusted live years. And you can see that the number of rupees that need to be spent for one quality in hemodialysis policy is greater than that for peritoneal dialysis. We have done a similar exercise for the health outcome and cost of the two dialysis modalities in India. And this particular slide shows you life years, quality adjusted life years, and total cost of treatment for the two dialysis modalities in India. And you can see that in terms of life years and quality adjusted life years, peritoneal dialysis is superior to hemodialysis, whereas in terms of cost, hemodialysis is more expensive than peritoneal dialysis. But again, we have to make sure that there is some sort of a cost control for peritoneal dialysis as well, because for hemodialysis, the government has been able to impose some sort of cost control, but peritoneal dialysis supplies are available at market prices similar to that in the Western countries. So currently, this is the price. And at this price point, peritoneal dialysis is not cost effective compared to the current price of hemodialysis in India. But if the price of peritoneal dialysis comes down, the peritoneal dialysis will become cost effective. And this is the point at which peritoneal dialysis will become really cheaper than hemodialysis in terms of providing dialysis to all population in India. So some sort of purchasing reform is essential. The final thing that is not often talked about is the nephrologist reimbursement. So I have shown to you two machines on this slide, and they look quite similar. And really, both the machines are used in analogous fashion by many nephrologists. So you have the hemodialysis machine and you have the ATM machine. So hemodialysis machine leads to immediate reimbursement and consistent reimbursement to nephrologists, whereas peritoneal dialysis does not provide same level of reimbursement to nephrologists in many low-income countries, and therefore that creates a disincentive for nephrologists to prescribe peritoneal dialysis. So in summary, we need two types of financial reforms, and the first is the reform in the way nephrologists and dialysis centers are reimbursed, so that the first thing that we need to do is to make the reimbursement equal for both types of dialysis, as is the norm in many high-income countries such as Australia, Canada, UK, and increasingly in US as well. And the second type of reform that is needed is a consumable pricing reform, which will be facilitated by local manufacturing, removing tariff barriers, and by undertaking strategic purchasing that only the government is able to do. Now, let's turn to medical barriers on home dialysis in the emerging countries or the global south. So the first thing that immediately comes to mind is the lack of expertise in peritoneal dialysis catheter insertion, the challenges related to providing dialysis to crash landers, which provides an easy excuse to start these patients on hemodialysis. The third issue, which has been brought up a few times, is unsuitable or not suitable home situation for many people who live in rural areas in low-income countries. And the final is delayed referrals, which provide few opportunities for shared decision-making so that the patient takes the default choice, which is in-center hemodialysis. Now, coming to the first one, catheter insertion programs, this is critical. And recognizing the importance of catheter insertion, many countries, for example, in India, in our program, even in medical and pediatric residency programs, insertion of peritoneal dialysis catheter is supposed to be an essential skill that every physician and every pediatrician needs to learn, so that when they go back and start their medical practice, even if they are not trained nephrologists, they know how to put in a PD catheter and they can save lives. This program has been actually taken up by this Saving Young Lives initiative, which is a joint initiative of ISN with IPNA, EuroPD, and the International Society of Peritoneal Dialysis, and it has been implemented in African countries and many Southeast Asian countries, and it has helped save many lives of children with acute kidney injury. But the same can be used also to leverage this skill set in chronic dialysis catheter insertion. Now, the COVID pandemic has spurred us to think more about monitoring our patients remotely. And this is something which is critical for improving the care of patients on home dialysis, because one of the challenges that has been identified is that they feel disconnected and disempowered because they are not interacting with healthcare systems as frequently as patients on hemodialysis. Now, you will agree that using the smartphone as a central device and providing patients with access to these 4 or 5 peripheral devices, a thermometer to measure body temperature, a weighing scale to measure the the weight of a peritoneal dialysis fluid bag, a glucometer to measure blood sugar, a blood pressure instrument, and a pulse oximeter, especially in COVID times, will really simplify the management of these patients. Many units are now using remote monitoring techniques, and this is one such paper from Colombia, which used remote monitoring for 49 patients who were on automated peritoneal dialysis. And there they showed that patients who did not use remote patient monitoring compared to those who used patient monitoring, those who were on remote patient monitoring experience more prescription adjustments to improve or personalize their care. Their preemptive consultations rate was higher, and their blood pressure control was better. And so therefore, these authors concluded that remote patient monitoring has an early impact on automated peritoneal dialysis management by incentivizing therapy adjustments with the goal of optimizing patient care and improving clinical outcomes. And here is a second paper, at this time from United States, in which about 25% of about more than 6,000 adult patients on peritoneal dialysis were using remote monitoring tools. And these authors showed that the incidence rate of hospital admissions, the incidence rate of hospital days, and incidence rate of technical failure risk all of them were significantly lower in those who used remote monitoring. And these authors concluded that frequent use of remote monitoring application is associated with less hospital admission, shorter hospital length of stay, and lower technical failure rates. But despite all of this, in another study that looked at telehealth awareness of peritoneal dialysis patients in US, despite the fact that most of these patients had access to the enabling platforms, which is computer, tablet device, or smartphone, really very small proportion had either heard of telemedicine, were able to define telemedicine, and could correctly identify an example of telemedicine. So there is work for us to do here, and we need to inform people as to what telemedicine is and how it can improve their care. We have implemented one such program in India, which we call Support PD. And so this has several layers. So here is a patient on PD. So this is a patient-centric program. And this Support PD program provides an interactive clinical questionnaire. It allows patients to record their body weight, monitor their blood sugar, quality of life, blood pressure, and provides clinical oversight as well. And in the middle layer are alerts, alarms, and nudges, remote prescription management using a clinical decision support system, predictive analysis and tracking of complications, algorithm-driven clinical decision support, and a bidirectional communication system with the healthcare team. Ultimately, at the level of health system, we are expecting that it will achieve cost reduction. It will allow improved guideline-based care delivery, make the care more patient-centered and continuous, and allow us to do large-scale data analysis as well. Home dialysis clearly offers more opportunities for innovation in terms of education, training, home assessment, providing multidisciplinary care by using checklists and using this remote monitoring to assess visit preparedness as well. We in India have, along with the support PD tool, also started looking at task shifting, in which this person who is a village-based healthcare worker is able to perform the role of a frontline healthcare worker that can engage with a patient, often living in really deprived rural settings, and adjust their prescription and help them get the benefit of home dialysis. Sustainability, peritoneal dialysis clearly is more sustainable than hemodialysis, and I'm not going to go into the details of this, and this will be discussed elsewhere in this Congress. And therefore, we need to really change the mindset. And if we start thinking in terms of making therapy patient-centered, it is inevitable that we will continue our move towards home dialysis, where patient selects therapy, the treatment is of high quality, we listen to patients and make the therapy more flexible, and we engage in innovation which is driven by patients. For this, shared decision making is critical, and shared decision making should take into account not only clinical considerations, but also system level considerations related to the healthcare that is available in that particular jurisdiction, but also values and cultures of the patient, their lived experience, their life goals, information needs. And once we start thinking of that, we'll be able to make decisions which will probably take us in the direction of home dialysis. So what is going to be the future of home dialysis? This is something that the International Society of Nephrology at the George Institute thought of a few years ago and set up this affordable dialysis price, which was a search for a new disruptive affordable dialysis system that should be light, should be portable, and run on solar power. We asked the participants that they should develop a system that should be able to purify water from any source. It should be safe and effective, of course. It should cost less, both in terms of the initial infrastructure cost and the running cost. In March 2016, a global jury identified the winner, and at the time of call for this proposal, we were completely agnostic about the type of solution that would be offered by the different contestants. But as it turns out, that the winning entry actually was around peritoneal dialysis and not hemodialysis. So Vince Garvey has proposed that his system will prepare peritoneal dialysis fluid at the point of care using solar power and water from any source. The system will be controlled by a smartphone, and it will be really cheap. And he has made significant progress, set up a company, and is working in Australia, and has actually got a prototype which is ready to go into clinical trials. You must be wondering, I didn't talk about COVID-19, and of course, COVID-19 has given a huge fillip to the consideration of home dialysis rather, and a lot of webinars have been held around this particular topic, and I'm not going to talk any more about it. So in the end, home dialysis in the developing world can address the large unmet kidney failure treatment need, but we need to make the political and economic case. And the case is that home dialysis is consistent with the principles of universal health coverage. It can increase access and equity, and it is patient-centered. Once we have done that, we will need to develop and present a contextualized solution, which should be resource sensitive, but it should at the same time be quality-oriented, it should be innovative, and it should be participative. Having done all of that, we need to remember that we need to narrow the knowledge gap and promote shared decision making if this treatment is to be embraced by the entire community. I would like to, in the end, thank you all for your attention.